Greetings, everybody. Thank you for joining us today for session 2 of the Lurie Children's Roundtable with the Center of Cancer and Blood Disorders. We are here with Dr. Elizabeth Sokol. She will discuss the advances in care of children with solid tumors and the role of early phase clinical trials. My name is Chad Worley. I'm your moderator, and I am the Lurie Children's Physician Liaison for the North and Northwest Suburbs. I am joined by liaison colleagues Paula Nowak and Julie Kalkbrenner. But before we move on, I'd like to tell you a little bit about our Lurie Children, the Center for Cancer and Blood Disorders at Lurie Children's. We treat more children with cancer and blood disorder than any other hospital in Illinois. And although cancer is rare in children, we treat 220 new patients each year with a wide range of childhood cancers. We are ranked #1 in Illinois and top 10 nationally by U.S. News and World Report for Pediatric Oncology. We see patients at our main hospital downtown, Arlington Heights, Central DuPage Hospital, Lake Forest Hospital, the Northwestern Medicine Proton Center in Warrenville, as well as in New Lenox, Northbrook, and Westchester. Dr. Sokol sees patients at our main hospital downtown. Her clinical focus centers on treatment of pediatric solid tumors, including those with neuroblastoma, sarcomas, rare tumors, renal tumors, liver tumors, and germ cell tumors. Through her work with Children's Oncology Group's Neuroblastoma Committee, she participates in the development of new therapeutic clinical trials for neuroblastoma patients. Before I turn it over to Dr. Sokol, I would like to remind everybody that we record these sessions and we encourage your engagement. So if you have questions during the presentation, please type them into the chat room or the Q&A section. And after the presentation, we will ask Dr. Sokol the questions. If you'd like to go live and ask the question, just click on the raise your hand icon and I will unmute you afterwards. But without further ado, Dr. Sokol, thank you for joining us today. I'm going to turn the screen over to you. I'm going to stop sharing and I'm going to let you take it over.
Absolutely. Thank you. Great. All right. So as Chad said here, we're going to talk about the advances in care of children with solid tumors and the role of early phase clinical trials in our patients. So launching into this here. There we go. All right. So what are we talking about when we say pediatric solid tumors? This really covers a range of types of diagnoses in a number of categories here. I'll mention some, although I can't possibly mention all of the types of tumors that we take care of. But the most common include the embryonal tumors or tumors of development. These are things like neuroblastoma that arise from the peripheral nervous tissue, Wilms tumor or nephroblastoma, a developmental tumor of kidney origin, hepatoblastoma, the most common liver tumor in our youngest patients. This includes sarcomas, which can occur in any age group, but we see a rise in our adolescent and young adult populations. Our bone tumors, osteosarcoma and Ewing sarcoma, and our soft tissue sarcomas, both the rhabdomyosarcoma group as well as the non-rhabdo soft tissue sarcomas, which encompass a wide variety of different tumor types. We see patients with germ cell tumors that can arise in the testes and ovaries or elsewhere in the body throughout the age range, neuroendocrine tumors, and a variety of other rare pediatric tumors. These can include some things that are more common in our adult counterparts, things like hepatocellular carcinoma or melanoma, and other rare developmental tumors as well. Solid tumors also can include those CNS tumors, although that will not be referred to so much here in this presentation today. So with such a wide array of types of tumors, the clinical presentations can be quite variable. What makes it hard in identifying when these things are happening in our patients is the symptoms can be pretty nonspecific. Oftentimes, we have patients present with fatigue, pallor, fever. symptoms that happen for such a huge variety of reasons in pediatric patients that are usually not related to an oncologic process. They can have pain or lymphadenopathy, which again, did they just fall on the playground or is there something more serious happening? When our patients present with metastatic disease, we often see more of these nonspecific symptoms, and it can be hard to identify that these things are happening. And a greater percentage of patients with pediatric solid tumors compared to those with in the adult world do present with widespread disease. We also see some very specific symptoms related to the primary location of any tumor. So in our patients that have tumors in the head and neck region, this can often be some of the rhabdomyosarcoma or other non-rhabdo soft tissue sarcoma groups. They may have ear pain or rhinitis or pharyngitis that just does not seem to be responding to antibiotics as you might expect. For our patients with abdominal tumors, they may have constipation, more rarely diarrhea or vomiting and nausea, abdominal pain, which again, of course, have many, many etiologies that can cause those symptoms in our patients. Patients with tumors low down in the pelvis can have hematuria or trouble voiding. And some of these patients will have a palpable mass that tells us to identify that there's a problem. And sometimes that's the only thing that's identified. The child otherwise seems like they're doing just fine. And we feel something in their abdomen. So the treatment that we have for these patients has really evolved over the years through a number of cooperative groups that have come together to evaluate how to do better for these patients, how to better identify their diagnoses and how to better treat them. All types of pediatric tumors are rare in comparison to breast cancer or colon cancer. These things are very uncommon, fortunately. And in order to really study them and to do better, we have to rely on our cooperative groups. So the Children's Oncology Group is currently the primary cooperative group in North America, an organization founded in the year 2000 with committees focused on all different parts of pediatric cancer care. There are committees dedicated to each different cancer type, as well as those that focus on supportive care, optimizing nausea management, optimizing in control of infections and other supportive care needs like that for our patients. Their focus on biology, how these tumors occur, how we better identify novel and new therapeutic strategies to understand why they behave the way that they do. A range of clinical trials, from pilot studies just assessing the feasibility of including different types of therapies in these patients, to early phase clinical trials, the phase 1 trials that bring novel agents into the pediatric realm, phase 2 trials that look at signals of how well they are working, and our phase 3 trials that really define the standard of care for our pediatric oncology patients. There's also a growing body of survivorship trials looking at the fact that we are really doing better in curing patients with a variety of types of tumors, both solid and other, and specifically other types as well. And how do we make sure that we're optimizing the long-term health of these patients? So a lot of work gets done through these cooperative groups and through the Children's Oncology Group to really understand and optimize the care that our patients are receiving. These treatment strategies for pediatric solid tumors really involve a multi-modal approach, utilizing different forms of therapy coming together to treat these patients. Most of our treatment focuses on the use of chemotherapies, radiation therapies, and surgery in various combinations, but our more modern trials are including more and more targeted therapies and immunotherapies to really help to optimize the likelihood of cure for our patients and really to start to decrease the toxicity burden associated with our treatments. I'll go through neuroblastoma as just an example of how things have progressed over the years through a variety of cooperative group trials. So I present here to you 2 sets of survival curves, looking at how patients with various risk groups of neuroblastoma fare. So neuroblastoma patients are divided based on a number of features into low, intermediate, and high risk disease. As you can see, based on all of these curves, that patients with low and intermediate risk disease do quite well, with excellent event-free survival rates, and nearly everyone surviving from their tumor. Those patients with high-risk disease, however, have significantly worse outcomes than the low and intermediate risk counterparts. But when we compare from this early cohort, who was treated between 1986 and 2001, we have 2,600 patients here. The patients with high-risk disease had an event-free survival rate, as we approach 10 years, of about 30%. It means the majority of patients had episodes of relapse or disease progression, or toxicity, secondary malignancies, some kind of event that impaired their survival from their tumor. As we look at the more modern disease cohort here, treated between the year 2007 and 2017, we see that we've made some progress. The event-free survival now is closer to about 50%, not still where we would like it to be. Of course, we aim to cure all patients with this diagnosis, but we are making progress forward through the additions of various types of therapy to a treatment. So what has made these changes and what has led to the improved outcomes for these patients? Well, this is a summary of what the overall treatment strategy looks like for these patients. This is complex and the details here are maybe not as important at this time, but we use a cassette here where we have an induction involving 5 cycles of chemotherapy with surgery to remove the primary tumor, as well as a collection of peripheral blood stem cells that are used later on here. We see that we included 2 autologous stem cell transplants in a mechanism to give patients higher doses of chemotherapy in order to truly try to eradicate the remaining tumor cells. Radiation to primary tumor sites or residual areas of disease once we've gotten through the induction phase, and an immunotherapy phase at the end, where we are able to utilize a targeted immunotherapy agent to try to reduce any burden of individual cells remaining in the body. This therapeutic strategy has come to be through a series of clinical trials. I will show you some data here from the last 2 clinical trials that has led us to this being the standard of care for treatment of high-risk disease in this country. Here we have some survival curves that are a bit blurry, and I apologize for that. Looking at the data from the most recent clinical trial for patients with high-risk disease through the Children's Oncology Group. This trial was a randomized study comparing those patients who received a single autologous stem cell transplant to those who received tandem autologous transplants. And the top 2 curves here are the event-free survival and overall survival for these patients. And this is all patients who are enrolled on the study. And what we can see is that there is a statistically significant difference between the survival of the event-free survival of patients who received a single transplant versus those who received tandem transplants, having superior event-free survival. And although not statistically significant, you can see that the shape of the curve leads towards difference in overall survival as well. When we look at the cohort of patients within this trial who all received immunotherapy after their stem cell transplant, we see that the difference becomes even more stark, that the patients who received tandem autologous transplants have superior event-free and overall survival than those who received a single transplant. And so this study really informed the standard of care treatment for these patients. I alluded to the second part of that figure in the patients who had immunotherapy. So that brings us back to another trial that was done in high-risk patients that did overlap with the trial data I just showed you. And this was a trial that looked in a randomized way at the inclusion of the medication dinutuximab, which is a targeted immunotherapy agent that attacks a GD2, which is a cell surface protein on neuroblastoma cells. And in this study, we randomized the addition of this dinutuximab to standard therapy, which includes the use of retinoic acid in these patients. And it was found that, again, the overall and event-free survival outcomes were significantly improved in the patients who received the immunotherapy, the dinutuximab, bringing this into the standard of care therapeutic approach as well. And this was a really landmark study in that this was the first FDA-approved medication with specifically a pediatric oncology indication. So this was a really important move forward in the world of pediatric oncology in order to really study from the creation of a new agent to FDA approval and bringing this forward for our patients. So we have all these steps forward, but we still have patients who either, despite all of this therapy, have recurrent disease or whose disease does not respond to the standard therapy as we expect that they will. These patients provide a significant challenge for the field. We need novel therapeutic strategies, novel treatment options for these patients who have already often received significant therapeutic burden with significant toxicity and potentially disease that is refractory despite that. When we look at these groups of patients, we talked about all pediatric oncology patients being in rare groups. When we think about those that specifically have relapsed or refractory disease, we're looking at even smaller cohorts. And so the collaborations between institutions nationally and internationally are critical to bring new agents forward. The Pediatric Early Phase Clinical Trial Network is a group within the Children's Oncology Group that is supported by the National Cancer Institute, NCI, made up of a group of select COG institutions that really aim to bring novel agents forward into clinical trials for pediatric patients. This group has a focus on the phase 1 and phase 2 clinical trials. The phase 1 trials looking at the safety and proper dosage of novel agents, and the phase 2 trials that start to evaluate efficacy in certain disease cohorts and collecting ongoing safety data. These trials rely on significant partnership with pharmaceutical companies who are developing these new agents and maybe looking at these agents in other contexts in the adult world and bringing those forward to be studied in the pediatric context. This group has really been focused on increasing use of targeted and immunotherapies as the burden of conventional chemotherapy and radiation that these patients have already received by the time that they are often eligible for these early phase clinical trials is very high. And so we really need to think about how we treat these patients differently, not just with more drugs, but different ways of attacking these tumor cells. We at Lurie are a part of this Pediatric Early Phase Clinical Trial Network, and so really try to bring forth clinical trial options to our patients who may not have significant other therapeutic options. Here, I'll give you a couple of examples of trials that are currently being conducted through this early phase trial network, and give you a sense of how these are designed. So Tekavivint is a small molecule inhibitor of the Wnt beta-catenin signaling pathway. This is a pathway that's known to be altered in a number of different types of malignancies. It lists here a couple of those types of tumors. So desmoid tumors are soft tissue sarcomas that can be locally aggressive, but are biologically known to be driven by increased beta-catenin in the tumor cells. And so an agent that may target that pathway, may target the beta-catenin pathway, is a optimal option for these particular patients. Other tumor types that have been identified, so a variety of liver tumors are known to be dependent on this Wnt beta-catenin pathway. This includes both hepatoblastoma as well as the more adult counterparts of hepatocellular carcinoma that we will see more often in our adolescent patients. Renal tumors, including Wilms tumor as well, has about 30% of Wilms tumor cases have alterations in this Wnt beta-catenin signaling pathway as well. So a number of tumors that we treat very frequently in pediatrics have known drivers biologically that are impacted by this pathway. And so an inhibitor of this pathway is a really nice biologically driven option for a variety of our patients. So this trial is designed as a phase 1/2 study. So the initial phase of the study, the phase 1 cohort, evaluated the safety and identified the pediatric recommended dose for this agent. And then there are several phase 2 expansion cohorts that are being evaluated based on the biology of the tumors. So I have a list here of the sets of patients that are eligible for these studies. Patients with Ewing sarcoma, patients with desmoid tumors, osteosarcoma, liver tumors, Wilms tumors, and a grab bag for other tumors with known Wnt pathway alterations. These patients are all eligible for the phase 2 component of this study that are now currently open and underway. And if there are patients with these tumors who have received conventional therapy and have recurrence of their disease, this is an excellent option for our patients. So far, it seems to be very well tolerated, and we have several patients currently enrolled in this particular study. Thinking more from the immunotherapy perspective and how we're utilizing that through the PEP early phase trial network, this is another one of the phase 1/2 study through this mechanism, looking at a combination of agents, looking at tiragolumab and atezolizumab. These are two different immunotherapy agents. The first is a TIGIT inhibitor, which is an agent that inhibits both T cells and NK cell function. And atezolizumab is a PD-L1 inhibitor, blocks the binding of PD-1 to the PD-L1 ligand, and prevents the tumor's impact of suppression of the immune system. So when these inhibitors block that binding, it unleashes the immune system's ability to fight the tumors in the body. And so these two agents together really helps to stimulate the immune response against tumors in the body. SMARCA4 and SMARCB1 are two different genes that are known to be altered in a variety of tumors. Often we look for these two genes being deficient. And through a variety of biology studies, again, tumors that are deficient in these two genes are known to have increased numbers of tumor-infiltrating lymphocytes. So there's an increased immune infiltrate within the tumors themselves. The lymphocytes are there, but left without treatment, they're not able to kill the tumor cells. And so in tumors with known SMARCA4 or SMARCB1 deficiencies, we are trying to target them with immunotherapies that will allow those T cells and NK cells to truly fight the tumor. So in terms of the cohorts eligible for this study, the phase 1 study again is looking at the safety and identifying what the appropriate dose is for our pediatric patients. And in the phase 2 component, we have cohorts for renal medullary carcinomas, malignant rhabdoid tumors, atypical teratoid rhabdoid tumors, or the CNS component or counterpart to the rhabdoid tumor, poorly differentiated chordomas, epithelioid sarcomas, and again, a grab bag for other tumors who have known deficiencies in SMARCB1 or SMARCA4. So again, really targeting the tumor types that are known to have these types of abnormalities that are more likely to be benefited by these immunotherapies. So although there are several very promising trials through the early phase trial network, there are a series of problems that get in the way of really optimal drug development in our pediatric patients. As we've mentioned several times now, we're talking often about small patient numbers in comparison to adult oncology. And so it takes quite a bit longer to complete the trials to prove efficacy in these disease groups. And there's increased regulatory oversight for our minors, as there should be. We want to make sure that we're not doing anything that's putting our young children at greater risk. But there are increased requirements needed to make sure that these trials are done safely in children. The other thing is a little bit more financially driven, often on the side of the pharmaceutical companies. Even when there are positive trials, even when there appears to be an agent that is very promising for a pediatric cancer indication, if the trials that are being done in the adult world are not successful, oftentimes there's not a financial incentive for the companies to continue production of that agent. So if the indication is only going to be for pediatrics and it was not successful in the adult world, the company often will pull the agent and stop the trial mid-trial even, because there is not enough use for that drug. There are several pieces of government regulation that have required the pharmaceutical companies to increase trials in pediatrics. But it doesn't always fix some of the above mentioned issues. There's two acts in overall that have been very helpful in increasing the study of new agents in pediatrics. So there's the Pediatric Research Equity Act, which has required companies to assess safety and effectiveness of new drugs or biologics in pediatric patients. So as they're applying for FDA approval for new agents, they do have to have pediatric studies on board. So this helps to initiate these trials oftentimes. And there's the Best Pharmaceuticals for Children Act, which actually has provided some financial incentive to companies to voluntarily conduct pediatric trials. So there are both requirement and regulation, as well as some financial incentive for these companies to do these things. But at the end of the day, these companies are in business to make money and to make sure that there's going to be a broad audience for their product. And the pediatric world does not always provide what the companies are looking for these agents. But despite these things, there is ongoing work and ongoing partnership and new trials being formed, both through the clinical trial network and through the Children's Oncology Group, as well as with direct partnerships with pharmaceutical partners through lots of investigators across the country. And we are making progress in treating patients with relapsed and refractory disease, as well as in the upfront setting. Well, with that, I'll be happy to take any questions or comments that the audience has.
Thank you for that. That was a really great presentation. Lots to learn about your studies. And with that in mind, I'm sure there's a question of, these studies are great. How do we get involved in that? Or how can we send a patient or refer a patient regarding that? Can you give a little insight on that?
Yeah, absolutely. So we have pretty easy way to if you have a patient who you're interested in referring to see, is there a clinical trial that they may be eligible for, or to see what's happening, we're always open to communication via email. I myself personally receive emails pretty frequently saying, hi, do you have something for this particular patient? We also, if you have a new patient who you think may have one of the types of tumors that we deal with, that we do have a easy email, the new solid tumor at lurie-childrens.org, that you can reach out to at any time to connect with our clinical coordinator and our APN, who helps to coordinate getting new patients connected to care appropriately. In terms of trying to understand just what trials may be out there, all of the trials are listed on the clinicaltrials.gov website. And we are listed as a site for all of the cooperative group trials that we have available. And so we do find that providers also find us through that mechanism, that as they're looking for trial options for patients with relapsed disease, and can find our contact information through that way as well, and see if there are trials that are appealing or look promising for the particular diagnosis that a patient may have. But I would say always, if there are questions about it, I would feel free to reach out to us, and happy to talk through whether there's an option that makes sense. And furthermore, if there are slots, that these phase 1 clinical trials run based on slot availability and fill to a certain point before evaluations are done, to make sure that everything is done safely. And so even if we have a trial open, there is not always availability for enrollment. And so having a conversation about that ahead of time can be quite helpful.
Okay. For those out there listening, you could always contact your liaison for direct links and questions, and we can contact Dr. Sokol for you, and then we can be your mediator and get everybody in touch with the right people for that. So we're happy to do so. But unfortunately, we are out of time as we hit the 30-minute mark. And I just want to thank you, Dr. Sokol, for being with us today. It was great for our providers out in the community to get to see you and get to know a little bit about what you're doing here at Lurie Children's.
All right. Thank you.
Thank you. And thank you, everybody, for joining us today. I'd like to invite you to join us for session 3 next Tuesday, May 16th at 7:30 a.m., as we'll be discussing advances in curative therapies for non-malignant blood disorders. So until then, thank you for joining us, and we will see you soon. Have a great day.